We are so glad that you guys came to listen to us and are giving us a little bit of your time. To me, this kind of fell in our lap. We spent a little time. What we want you to do is we want you to know that this is what we want you to be able to do when we're done. We want you to be able to discuss the application of Lenburg's competency outcomes performance assessment model. And we use this to enhance the clinical evaluation process. And I look out here and I see some of these people in the audience, and they were the very people that we tried this on. And we also want you to be able to discuss the process of developing and implementing an evidence-based tool for clinical evaluation, which was new and fun for us as we developed our own rubrics and tools to evaluate in a clinical setting.
Just to give you a little background on this project, it's based on a conceptual framework, competency outcomes performance assessment, and this is called the COPA model. So we're going to refer to it as the COPA model. And this is it's a theoretical framework that was developed by Lenburg in the 1990s, and it was done in an effort to promote quality care and competence in nursing. Several national initiatives, the IHI, the QSIN, and the IOM reports focus on increasing the emphasis on patient safety and competence in clinical practice. And therefore, nursing education at all different levels are trying to explore the meanings and the definitions and specific wording of competencies and ways to improve their use, especially in this situation, the clinical setting. The COPA model has 4 conceptual pillars that it's founded on. The first one is identification of essential core practice competencies. Each of these competencies is learned and assessed individually and must be clustered under one or more of 8 universal core competencies, and we'll talk more about those later. The second pillar is end result competency outcomes. Traditionally worded objectives are converted to end result outcome statements. They're integral to practice and worded as practice expectations. Basically, that's answering the question, what do nurses do in practice? And the third pillar is practice-driven interactive learning strategies. These will become clearer when you relate them to core competencies and clearly worded outcomes, which are identified in the pillar 1 and 2. And in pillar 4, objective competency performance evaluations. This is how do we know whether the competencies are being met. The COPA model, application of the COPA model to curriculum can prove to be quite challenging. It requires faculty to work collaboratively and realistically to address and resolve 4 fundamental questions. The questions that must be asked are, what are the essential competencies that are required for practice? What are the things that the students must become competent at? The second question is, what are the most effective outcome statements to integrate these competencies? How do we define those outcome statements? And what are the most effective interactive learning strategies to promote achievement of the outcomes? And fourth, and this is the one that we dealt with the most, what are the most effective performance assessment methods that validate achievement of the outcomes? The 8 core practice competency categories, which you will see in a moment when Paula shows our evaluation tools, these 8 are integrated throughout our curriculum at Covenant School of Nursing, and they're the assessment and intervention, communication, critical thinking skills, human caring, teaching skills, management skills, leadership, and knowledge integration. And these, like I said, are the basis of the Covenant School of Nursing curriculum.
And we were based on a current COPA model out at the School of Nursing, and we used this assessment tool when I started out there. And this assessment tool follows along with the COPA model every step of the way. And it has individual items that fall under each portion of it. And under each portion of that, it gives you another step that has to be followed. For example, if we're talking about assessment and intervention, 1A underneath that is analyze data collected when formulating a comprehensive plan of care. And then another step under that, and another step under that. And as I started out there, and I began to learn how to use the tool, I realized that this tool is very lofty for me. and it was very subjective. And everybody had a different answer for me as I went to find out how to use this tool. And everybody was using it in a different way. So, very subjective way to address these students in the clinical setting. We then added a second page which incorporated their clinical paperwork, which gave us something solid to look at, to compare, which was not subjective. This was the paperwork that they turned into us on a weekly basis. So we felt like we were moving along really, really well there. But the longer that I was out there, the more frustrated I became because I had nothing that I felt like was tangible that I could touch and feel when I were evaluating them in the clinical setting. So we had this problem. We went to curriculum with this problem. The 401 semester didn't have a defined clinical evaluation process. And this was our SBAR. This is the way that we bring problems to curriculum to address, to see what we can do about it. The process was subjective, inconsistent, and it lacked rigor. It means that anything, any way anybody wanted to address it was free game. So the clinical expectations in the various units that we had were not clearly defined, and the students were not engaged in the clinical experience. And there was no intrinsic value placed on our clinical performance. So we have 360 clinical hours. And to have no intrinsic value and to have them not engaged for 360 hours was something that I couldn't fathom. So we are divided up into 8 primary units in the 401 setting. We're at skill labs, high fidelity sim, we're in the ED, we're in peri-op, we're in SICU, MICU, and then leadership, which is 2 separate places. It's total patient care and it's team lead. What happened after that was we began to develop rubrics. This was the initial grading rubric that you can see right here that followed along with the COPA model, very, very basic, very simple to use, that we began to grade, and it was used in the simulation lab. And that was great, but it didn't cover all of the areas. So then I began to sit down and develop a rubric that fit me, that followed COPA when I was doing surgical intensive care. And the second rubric that you see here is what came from that. Now, while I developed this rubric, and it falls within each area of the COPA model, all of the 8 areas, it has a question that I could ask that became something tangible. I also gave myself a legend so that I could grade them the same way every time, every day, every student. So if I didn't feel good that day, it didn't matter. Everybody got the same grade, or the grade that they answered the question. As we went along, we developed more rubrics because I was then moved to the emergency department. And so I developed a rubric for the emergency department to fit me, and someone else was moved up to SI, and they adjusted the SI rubric to fit them. And then leadership and management sat down with me, and we developed a rubric to fit them. And we also had a rubric for simulation, and we also had a checkoff sheet for simulation. So as they performed in simulation, then you could check off exactly what they did. So everyone was getting checked off on their actual skills, as well as following the COPA model. This was great for me because this was something that was tangible, that I could touch, that I knew I was doing the same thing every time with every student. So I felt like then my big, lofty initial evaluation tool had meaning for me. Because with these questions, I was able to go back then and fill out their grading process, whether they passed or failed, whether they needed improvement. I had a means to supply those pass or fails or those needed improvements. Also, with this came the fact that the student knew immediately, because we did these rubrics together, so they knew immediately where they stood, how things were going for them. They had immediate feedback, and then there was no question. Because if I gave them a needs improvement, they knew exactly why. So there wasn't much going to the coordinator and saying, I don't understand why Ms. Ponder is giving me a needs improvement in this. They knew why because we had already discussed it. So I felt pretty good about that. And it fit our COPA model. Then we decided, there you go.
We decided to take this one step further and actually do a little bit of a study, a mixed method study on it. Most of you in here are nurses, and you realize there's a global shortage of nurses, and patient acuity is rising. And there's data that suggests that nursing competency has declined. So there's a need for evidence-based strategies to facilitate effective evaluation of clinical competencies to know whether or not what we're doing is working. So the purpose of this project was to evaluate utilization of Lenburg's COPA model in guiding the development and implementation of an evidence-based clinical tool and their impact on nursing students' clinical engagement and competency. So that was our purpose.
So we had to develop some research questions. And as we looked back at what had happened after we began to use these rubrics, when we gave them expectations, because these rubrics were posted on our learning system so that they could print them off prior to clinical. Therefore, they knew their expectations in advance. So they knew that when they were with me in the emergency department, I was going to ask them specifically about medication rights and how do you use medication rights in the emergency department, and give me an example based on your experience today. They knew that was going to happen. So what we needed to know then was, when we used this evaluation tool, did it increase their clinical engagement? And did it increase their competency measured by faculty evaluation through course and clinical grades? And did the use of the evaluation tool increase student self-reported engagement, competency, and attainment of course outcomes? So when we use this, then could they sit down and tell us that, yes, you know, I feel like I got what I needed to get? Did I attain the course outcomes? Because everybody has course outcomes in their syllabus. So were they achieving those outcomes? So we used a mixed method. We did this over a couple of semesters, a couple of years. It went very fast for me. So we did this over a couple of years, and we collected our rubrics. We collected surveys that they did for us. We did a literature review based on what the literature said about rubrics and were they evidence-based tools. And the unit-specific rubrics were based on Lenburg's COPA model. We developed them and we implemented them to our senior level students. And we had data.
Data. Everybody loves data. Okay, so what we found out about this was whenever we identified that problem, just like Kathy and Paula are talking about, that when we were in the clinical setting, we went to evaluate the students, and it seemed based on the COPA criteria, those 8 criteria, which we have 7 where we combine leadership and management together, we had to look at that, and we have all these diverse 8 units, and each instructor evaluated however they saw fit, and it just seemed real vague, just like they were talking about. And so we thought, well, if you're in SICU, it's not going to be the same if you're in the peri-op setting. And it's not going to be the same as in the emergency department. It's not going to be the same where you're at. And so it was frustration when I became the coordinator. I noticed it was frustration across the whole level. And all of this work was done at the senior level. And so what we found out was if you start playing with this stuff and trying to change some of the approaches to the evaluation model, everybody wants to know what's going on with that. They want to know, okay, now what's going on and why this, and let's try to keep all this pretty consistent. So when we started gathering the data, we wanted to make sure that we looked at it from every possible direction. Every possible direction. And how is it going to impact, one, how's it going to impact the students and their performance? Because we wanted to increase the engagement. And we wanted clear expectations for them so that they knew this is what I'm looking for. When you come to the emergency department and you're with Ms. Ponder, here's the criteria. Based on Lenburg, this is what she's looking for. So the student didn't come into the ER and go, well, I don't know what I'm supposed to do. I guess I'll stand over here. Or I'll go to lunch and then I'll stand over here. And so that was what the frustration that Paul was talking about at the beginning. So we wanted to gather data about that. So we looked at that from a qualitative standpoint and also from a quantitative standpoint. This was the quantitative data, and we looked at how it affected their overall clinical grade, based on that second page that you have, how it affected their clinical grade from that aspect, and because we're going to see any improvement with this. We wanted to see, if we're not going to get more engagement, they're not going to be more buy-in, and then it's not going to do us any good. Then we could just keep doing what we were doing. And we want to know what the perception was from the students' aspect and what kind of impact they was having across those units. We felt like it was going to have an impact, but what was the feedback going to be from the hospital and from the nurses and the charge nurses and the people in those units where those students were at? So we gathered all that data from all these different directions, looked at it on their grades. Kathy, you want to change that one? And then on the qualitative, we looked at, this is why Paula said 2 semesters. We did the rubrics for 2 semesters, and then we compared them to the prior 2 semesters.
Oh,
and so
yeah.
That's where the 2, so the prior 2 were the control, and then the 2 that we ran with the rubrics are how we compared those. And so what we found, and that was across fall 2010, spring 11, and then fall 2009 and spring 10 where the semester we compared to. Then we used a Likert type response on the end of semester surveys for the course outcomes, for the senior level course outcomes, to gather data to see were they meeting the course outcomes at that level, and then also their exit survey. We did the exit survey when the seniors graduated, and they'd fill out and talk about if they met the program, the overall program outcomes, and if it had any impact on that and their perception of that. And then there's also on those surveys, there's a narrative part where the seniors could write and just express their feelings about that. So that was our qualitative data. Findings. What we found, and this is in your handouts, and Patty's making some handouts for the other half of the class. Sorry about that. We didn't think this many show up. We actually had a little bet going about how many would be, and Kathy won. So what you see, just in general, the first 2 columns are the first 2 on the left are the semesters that we used the rubrics. And on all of the 4-1, that semester level outcomes, there was an increase, a significant increase, in how they felt about the specific Lenburg competencies in each of those areas. So we were kind of excited about that, because that was the impact that we wanted it to have. We wanted the seniors to feel like, I'm getting a better education, and I feel like it's making me more competent and better as I go out to work. Okay. So that was the course outcome. The exit survey is for the curriculum outcomes, for the program outcomes overall. And there was a significant impact, again, it's on the left side, was the last semester that we used those rubrics, and it seemed to be having exactly the effect that we wanted it to have in all of the areas, all 7 criteria. So this just kind of sums it up. We collected over the 2 years, it's 250 students that we looked at. We're a diploma program. After implementing now this is interesting, what we thought was interesting, because look at this, after implementing the grading rubrics, the clinical grade, just the clinical aspect of it, not their overall grade, there was an increase from 93.7 to 97.2% on the grades. And people look at it and they're looking at it and they think, that's a high grade. Those are really high. We'd be happy with the 93.7. But the thing to remember about that is that we're at the senior level. That was the expectation, is that they should be very competent at this point and at this level. So keep that in mind, that when we're evaluating them, they do perform well, especially at that senior level. So that increase for us was pretty significant. They were already doing well, and it's like with a more intense, this is what it was, a more engaged, a more intense, more rigor in the evaluation, they did even better. And like Paula was talking about, and Kathy was talking about, we had, but before, in the years before, whenever you would put the grade on there, on that shows on the first page, you put a P, or you put, and you wouldn't hear anything. But as soon as you put a needs improvement, or the F, oh, here they come. And that was fun, because they'd come and say, well, what is that? And you'd have a little anecdotal note on that page that discussed that, but it wasn't specific. When we started using the rubrics, when you put a needs improvement, no one came to talk to me. I was the coordinator. And in those 2 semesters, had 1 student in each semester that came, discussed with me. We had the rubrics. It was spelled out the exact criteria. Where they came a little short, we talked about it, and they said, you know what, Mr. Hill, I need to work on that. Yeah. I need to go work on that. And that was the end of it. There was no discussion about that. So they improved their engagement, they improved their performance, and they knew what the expectations were. And if there was a question, we could sit down and talk with them. And we discussed it and talk it through, and everything was fine. And they knew what to work on. And so we were just really jazzed about that piece of this whole study. And then on their overall course grade, the averages for those 2 semesters was 85, and it increased 85.2. And so what's the significance of that? That's not significant. And that was the beauty of it too, because what we didn't want to happen was all of a sudden we're padding their overall grade. And then this reflected that it doesn't pad it. They're still going to perform on a certain level in their clinical and theory, and when you combine it, it doesn't have that big of impact. It doesn't pad that grade where, oh, they're using clinicals to graduate. They're using clinicals to pass. So we were just thrilled about the whole thing and how it all worked out. On the surveys, 89.4% of the students believe, this is interesting, they believe the new evaluation method motivated them to be more engaged in the clinical setting. And that was just on the Likert. And let me see what the next comment is. Okay, back it up. Okay. The narrative part of that survey, it said they had increased motivation to excel. These are the comments that they made, the common themes. There's greater proficiency, and there's clear expectations. We saw that over and over through that from the students. But what was interesting about this, the ones in these comments also, I didn't put that up there, there was 89.4% that said, yes, I was more engaged and more motivated. There were comments in there that said, I don't need a rubric. When I go to clinicals, I'm engaged. I don't need this to motivate me. So even some of the negatives, some of the no's were qualified with, I'm motivated anyway, whether you do this or not. So that was even nice to see on this level. And so that was our findings.
Okay, so as far as our conclusion, Well, first of all, we concluded this is definitely a work in progress. While we recognize that change needs to happen in the evaluation methods and defining our competencies, this is a baby step in a beginning. And already, since we've done this 2 years of work, we're already working on changing our rubrics to make them even more appropriate and more effective in the future. So it's definitely a work in progress. That's one of our huge things that we concluded. But we also just concluded that innovative use of evidence-based evaluation methods in the clinical setting is needed, and this is across the board. This isn't just at Covenant School of Nursing. This is true. You'll read in all the literature. It's necessary. It's the progression and where we need to be going. So we need to keep that work going. The other conclusion we came to is utilizing this grading rubric, which was based on Lenburg's COPA model, for evaluating the student clinical experience did suggest that increased engagement, competency, and attainment of course outcomes did occur. So we were very excited about that, that we did find what we hoped to find. And also that just further research is merited, further work on the whole project needs to continue. This is, like I said, it's just the very beginning stages. And while the three of us decided to look at this in a study method and write it up and present it as research, there's many others in our level and at the School of Nursing that are on this path to excellence, and just where we're headed to go.
And for our further implications and future plans, let me just tell you that everything is based and going based to patient safety and competency and what are we going to do for the future. And for myself, I've already adjusted my own personal rubric to include the Texas Board of Nursing's differentiated essential competencies, because it helps me understand what I'm teaching and why I'm teaching it. I've also included my NCLEX plan, so it's what they need to learn to pass boards. So I've correlated those across the board with the things that my expectations for them so that I can evaluate them in a clinical setting. And we're pulling in the things that make a difference from the new IOM report and where we're going in the future. And are we going to be competent nurses? And are we going to take care of our community? And I'm very passionate about this because I'm thinking, be it big-headed or not, that we're making a difference in how they feel about their clinical experience and the end result of their clinical experience. And we do care maps, and knowing the expectations going in frees them to truly think outside the box and think about the puzzle pieces that they're putting together and give us some of the most incredible pieces of work for senior level students that you have ever seen. It is simply amazing. So some of these things are already coming to play for us, and it's exciting. And we just believe the rubric method is the way to go. We're ready now for you guys to ask us questions.
And I just want to add one thing before we do the questions. It's really exciting for us as faculty to see, I see at least 4 students that we've had
That were part of this.
That were part of this, but more importantly, that are now going on to take that next step and go further on this progress on the road to excellence. So it's really exciting to stand up here and see you guys that we just had. So thank you for being here.
Any questions? Yes,
on the students that you said had an intimate enough, or they said that they didn't need the rubric, they were motivated enough. Did you have intimate enough knowledge to know that they were engaged, or how do you measure that?
That's a good question. I don't know how you measure that or gauge that. What I didn't. I'm glad you asked that question. What I didn't add in there was the response and the feedback that we were getting from the units completely changed, because we had students that we would be making our rounds, and they would be sitting in the nurse's station with their feet propped up. And this is how bad it was. When the instructor comes around, what would you think the response would be? Oh, they'd sit there. They would sit there. They would sit there. And you gotta be, okay, what's going on? So it was a big change, and not only as faculty did we notice it, but everything that we were hearing back from the units, they were, what are you guys doing with these seniors? They're engaged. They're in the middle of things. They're asking questions. They're volunteering to get involved and do things. It was like a complete change. And so I don't know how you measure it, Dalton, but there was those that they just got it, and they're just that type of student anyway, right, Jason? I mean, there's just those out there. They're just going to do that. Yes, Leanne.
I think, being kind of new at seeing this, it's only fair that students have some idea how they're going to be graded in advance of what their performance is. And so using this rubric lets them know what we expect of them in advance of the actual grading process. So, it's black and white. If we find this and that, you're going to get marked off for this and that. And so, having the grading rubric, because we upload it for the students to see in advance, and knowing how they're going to be graded is really a huge difference in performance.
I have a question. People graduate, and then to keep their license, they have to have so many CEs. But from what I've been reading, sometimes they're just going along and taking whatever's there, but they're not really improving or growing as a nurse. And I'm wondering if I'm not going to say that the board needs to, but what if they had a self-evaluation based on the COPA model to prove that you're keeping confident, not just...
Yeah, in oncology setting, we are getting a new, when we have to recertify our certification, board certification, they are starting a new model which is called the assessment model of the studies. So they will give you credit if you do your assessment right after doing your CUs. Then only they'll give you the points. So that is coming now for oncology nursing, it's coming from 2012 onwards. So when I'm renewing it in 2016, I will be under that assessment model.
But that's a certification.
To renew your certification, we have to have 100 CUs.
Right.
Or presentations and everything.
Well, I'm thinking just with the 20 CEs that people have to have.
But if you're certified, they're inclusive. So like if you, like I'm a CCRN, so if I renew my CCRN certification, the 100 hours that I have to have for critical care are inclusive of the 20 that the board. Right. And now actually that's
But I'm just wondering if those 20 that the board is requiring us to have should be a self-evaluation of how you're keeping competent and you know what I'm saying?
Yeah, I understand what you're saying.
I think it's not the board's responsibility.
Right.
I think it's our responsibility as a practice to make sure that we're being competent, and I think that the hospitals and the continuing education departments in the hospitals, and I believe we will take over that, and I believe that we will somehow along the line go to some type of COPA model, and that we will be doing our competencies in the hospital, not based on taking a test on a computer, more showing me your skills in the hospital setting, or in your home health setting, or in your nursing home setting, or wherever it is you work. I believe that's going to be the wave of the future, because the patients have access to what we do and how well we do it. And I'll stop right there because Randall and Dondi want to say something.
Yeah.
I would say there are hospitals now that part of their interview process is a simulation activity.
I was going to say that.
Show your skills.
That's right.
They're doing it now. There are hospitals out there.
Yeah. The interview process is scenario based. You know, instead of just the panel, and scenario based, and then let's go to sim. Turn you loose. Let's see how you do.
I was wondering, do y'all just use this model on your senior level students, or do you implement it in the other?
So far, it's just the pilot study that we've been doing. So right now it's at the senior level, but other faculty members are looking at this and asking a lot of questions about it because they're seeing where we're going. Because it's the same problem at every level. Sure. You know, the same problem that we saw, it's the same everywhere. So they're interested in it, but we're in the early stages of it. Yeah.
And the skeleton process would be the same, but think of a 301.
Close it. I want to show them the whole.
Perform like a 401, so my
Right.
301s would have a different.
Correct.
Right.
Yeah.
And that's the
So
beauty
each
of
level's
that.
gonna have to write.
Their
Yeah.
own.
Yeah, that's the beauty of that. You know, if it's pediatrics that you're in, or if it's OB, or whatever situation. And that's why we did it in 401 at the senior level, was because every one of us was different, and the things that we were looking for were different. And so the students were frustrated. I mean, they switch units. I mean, I just got this figured out last week, and now it's all different. The expectations are all different. So that's where that came from. And so we'll see. We'll see how it goes. I was going to add this too about your question. What's interesting about I'm going to take just a poll. How many of you have heard of Carrie Lenburg and this COPA model? That's before today. Yeah, that's pretty good. That's pretty good. Because yeah, that's right. Because the interesting thing about that is the model that has been historically utilized is Benner's, novice to expert. And with the change, with the big question was, are we competent at the bedside? Are we competent at the bedside? Has seen this shift, or they're starting to look, or they're starting to look now, okay, how do we evaluate that? How do we evaluate that? Not just from a novice to expert level, but also the core clinical competencies. And that is exactly what Carrie Lenburg has done. And that's why we're so excited about going to Australia. She's already emailed and talked and said, you know, I'm just so thrilled that you guys are doing this and that you're working on this and getting this word out. I'm really surprised that many do about it. So we're just excited about doing this work and just continue forward with it. And where it ends up, we don't know.
And on that note, the entire school evaluation is based on the 8 core competencies. So in a way, yes, everybody uses the 8 core competencies. Does everybody use the rubrics? No, maybe yes, I don't know. But this specific thing is a senior level.
Are you all 3 senior teachers?
Yes, ma'am.
Is there anybody else?
There are more of us.
Leanne, Miss Fabry.
Miss Fabry is one. And there are 3 others. We're all using the rubric. Yes, ma'am.
I'd like to make a comment, if you don't mind, Mr. Hill.
Yes, sir.
And I don't want to speak for John and whoever else is in here, I didn't look behind me, but I really think that they would agree with me that, as being one of the few that are in here that actually have had this on them, that it really was a useful tool, and it really made you feel like you knew what exactly was expected of you. But at the same time, I also feel that if you were to put this into place with, say, 8 other teachers in a different school, I think another thing that's hard to measure is the closeness of how well that the teaching was in that semester. I mean, it was really good, and I think that's why you had such great success, because y'all really have good teaching, good teachers in that semester.
Thanks, Jason.
Just want to let y'all know that. And I think John can agree with that.
I was the first semester that used that, and I think he's absolutely right.
Thanks, yes. Thank you.
Thank you.
By the way, I need help with these teachers.
Yeah. And y'all meet me after class. I got your money. Yeah. Thank you. Thanks a lot.
Well, if it's all right, we'd like to let Dr. Ford, who this is broadly an area of expertise for her, provide a invited response.
It was these two came to me and said, you know, we've done this work and we got this data and we've got this idea, and it really is, could we move this forward? Is there some things we can do? So really, I just want to applaud Paula and Kathy for their work, and also Joanne, because when she came to me, we were just talking about, okay, great, yeah, we do. Well, what do we do with it? And so the first person we thought of was Joanne. And so we came over here, and she has been so instrumental in us. And I just want to applaud her too, and just thank them all for it.
Before she gets started, let me just say that this didn't come easy because there was some backlash at the School of Nursing when you try to change something to, to as big as this. So their persistence and all that's to be commended. So, and Mr. Hill for having dealt with the rest of the schools.
Leanne?
Yes.
I got a trip to Australia.
She's taking donations.
Well, welcome everyone. I just had a few words to say. Dr. Joanne gave you the title of my dissertation, and not so long ago I was in the literature looking at instructional methods for nursing education. And, we've heard about evidence-based practice in the literature here for 12 to 15 years. But when you go into the literature and begin to look at evidence-based nursing education, you don't find very much except about what the problems are. And they have brought some of the problems to you. One of the things was that nursing education tended to be teacher-centered and not student-centered. We had huge, massive curriculums that the teachers were struggling with, have to know it all. What do I need to know? So this is a lived experience of what you would read in the literature about problems with nursing education. Another problem that they talked about was the subjectivity. You might have one teacher and do it this way and you did well, and you would do for another teacher and you were not graded well. That is not a good thing. And so we have these three areas. We have the student, we have the education process, and then we have practice, which is very unique to nursing because our graduates of our schools need to make the transition from school theory to practice. It's a very challenging thing. But we as the educators want them to do well. So what can we do as the nurse educators to help them to make that transition easily? And then I wanted to make a couple points on practice. People in practice, our hospitals, our healthcare places, they have to be cost effective. They have to watch the dollar. And if you have a GM that comes into practice and they don't do well and they leave, and within the first year, that hospital has lost a lot of money. It can cost up to $75,000 to train a new nurse for a position. So that is not being cost effective at all. The other thing is if you think about outcomes, hospitals are tremendously concerned with patient outcomes. And if our nurses are not providing the kind of care that are going to create quality patient outcomes, that's not a good thing either for our GNs to go into practice. So when you go back and you read about Dr. Lenburg and her initial research into the problems with nursing education, things that I found when I did my literature review and the things that these guys found when they did their literature review, you can identify those problems that we have with nursing education. So to summarize it up, I want to say that this type of scholarship, this type of study that these faculty have chosen to do is a phenomenal thing and is promoted. The National League of Nursing, who is our accrediting body, said we need more evidence-based nursing education. They just support that. The way of doing it, the way we've always done it, is not working well. And so students can transfer, they transition to practice. You guys that were in this model, I would have worked with these faculty. I'm sure that you transitioned well to your role as a registered nurse because you were well prepared for it. The other thing about that is that the faculty knew what to evaluate. You heard Paula talk about her frustration about what do I look at? What do I do with, to be fair to the students? So that the faculty now know what to look at. Then, I want to say this one more time, that it promotes scholarship among the faculty, which is something that was a weakness of nurse educators. I'm going to close with this last comment. This is from Dr. Lenburg, that learners are oriented at the beginning of their course to the specific competencies and the requirements that they are expected to attain and what they will be evaluated on. Isn't that what every one of us wants when we are going to do something? Don't you want to know how you're going to be evaluated and what you're going to be evaluated on? And the other thing that occurred to me just as you were finishing up there, we talk in leadership a lot about being extrinsically motivated and intrinsically motivated. The old authoritarian model of the teacher coming on the floor and the students jumping up and scuttering to look busy, that is an old authoritarian model. And by moving to this type of model where the students know what they need to be doing and preparing and studying for, it switches it from being extrinsically motivated to intrinsically motivated, which when you read in the literature is the best way to be motivated. It's the kind of motivation that lasts. So I applaud you for your scholarship and your plan to implement this in your school. The literature would also support you and applaud you that nurse educators need to do this more. So way to go. Thank you.